Hello, my name is Dr. Frank Noto. I am an assistant professor of internal medicine at the Icahn School of Medicine at Mount Sinai. I am a practicing hospitalist at Elmhurst Hospital Center in Queens, New York. I also teach internal medicine and physiology for Kaplan Medical. I've been training residents and medical students for many years for Step 1, Step 2, and Step 3. I am here to prepare you for a very complicated section, renal physiology, but I can assure you, once you master renal physiology, this helps put perspective a lot of internal medicine. So as a practicing physician, every day I think about renal physiology. So a lot of what I teach you in this section, you will use for the rest of your career. So get your textbooks ready and have a lot of fun with the kidneys. The kidneys are a fun organ, and I'm here to convince you of that. Okay, so chapter 1 is the renal structure and glomerular function. So let's get started. So overview of the renal system. The kidneys are a very busy organ. Let's take a look at the functions of the kidneys. The kidneys excrete waste products such as urea, uric acid, and creatinine. The kidneys are responsible for water and electrolyte balance, and this is a very important function that we are going to continue to refer to. The kidneys are responsible for acid-base balance. The kidneys secrete the hormone erythropoietin and the enzyme renin into circulation. The kidneys are also responsible for hydroxylating 25-hydroxyvitamin D to form the active form of vitamin D, which is 1,25-dihydroxyvitamin D. And these are the functions of the kidneys. So the nephron is the functioning unit of the kidneys. And let's take a look at the structure of the nephron. So the kidneys are broken up into the cortex and the medulla. The medulla, you have the outer medulla and the inner medulla. Now in the cortex, you have the glomeruli. The glomeruli are surrounded by Bowman's capsule. After Bowman's capsule, the nephron becomes the proximal convoluted tubules. After the proximal convoluted tubules, the nephron becomes the descending loop of Henle, and the descending loop of Henle goes deep into the inner medulla. Then it loops around and becomes the ascending loop of Henle, then goes back into the cortex, and it becomes the distal convoluted tubules. Then after the distal convoluted tubules, the nephron becomes the collecting ducts. Now the collecting ducts are what I like to call, we fine-tune the urine. There are several hormones that act in the collecting ducts, and we'll come back to this a little bit later to talk about the very important function of the collecting ducts. After the collecting ducts, you drain into the renal pelvis. From the renal pelvis, the urine drains into the ureters, and then eventually into the bladder, into the urethra. Now, if you look at the blood supply, you have blood entering the kidneys through the renal arteries. The renal arteries will break down into the afferent arterioles. Then the afferent arterioles will become the glomerular capillaries. And here are the glomerular capillaries. And the glomerular capillaries are surrounded by Bowman's capsule, and this is where filtration occurs. After the glomeruli, you have the efferent arterioles. After the efferent arterioles, you have the peritubular capillaries. And the peritubular capillaries wrap around the rest of the nephron. So imagine the peritubular capillaries as surrounding the rest of the nephron over here. And they go all the way around deep into the medulla. Now, the peritubular capillaries we call the vasa recta. Blood flow through the vasa recta is very, very slow. And that's an important concept that we'll get back to later on in this section. But because there is slow blood flow through the vasa recta, that makes the kidneys very vulnerable to necrosis. So in situations where the kidneys have low blood flow, you get acute tubular necrosis. because of the low blood flow through the vasa recta. And we will come back to this later on in this section. And this summarizes the structure of the nephron. Okay, so now we're going to talk about the four basic processes of the nephron. So we're going to talk about the function. We looked at the structure. Now we're going to discuss the function of the nephron. So the function of the nephron is four basic processes. You have filtration. Filtration occurs at Bowman's capsule. Reabsorption occurs throughout the rest of the nephron. Then you have secretion, and then you have excretion. These are the four basic processes of the nephron. Now let's spend a little time looking at each process in a little more detail. The first process is filtration. Filtration is the process by which plasma is filtered by the nephron. And this happens at the glomeruli. So filtration occurs at the glomeruli. Filtration is driven by Starling forces. Filtration is driven by the glomerular capillary hydrostatic pressure. It is the hydrostatic pressure that drives filtration. If you increase the hydrostatic pressure, you increase filtration. And that basically pushes plasma out of the glomerular capillaries and into Bowman's capsule. And that's filtration. Now, the filtration rate, otherwise known as a filtered load, it's the same concept, quite simply is the amount of a substance that is filtered at the glomeruli at a given time unit. So therefore the units are milligrams per minute. Renal physiology is all about units. One basic concept you must understand in renal physiology is know your units. We're going to see a lot of calculations as we go through this section. If you remember your units, you will not make a mistake with your calculations. Always go back to your units to understand the basic definitions of the terminology we are talking about. So once again, filtration rate or filter load basically means how much, what amount, or how many milligrams of a substance, let's say creatinine for example, that's a substance. How many milligrams of creatinine am I filtering at the glomeruli in a given minute? Therefore, my units for filtration rate or filter load are milligrams per minute. And that is the definition of filtration rate or filter load. What amount, how many milligrams of a substance am I filtering in a minute? Milligrams per minute. Always think of your units and make sure you understand these concepts. Reabsorption is a process by which solutes and water are removed from the ultrafiltrate that was formed in Bowman's space and transported back into the plasma. This is a process by which solutes are taken out of the ultrafiltrate in the tubule and placed into the plasma in the peritubular capillaries. Reabsorption occurs at a certain rate. Everything in renal physiology occurs at a rate just like reabsorption. So when the test asks you to calculate the reabsorption rate, what they're asking you for is what amount or how much of a certain solute was reabsorbed from the ultrafiltrate. So if you remember your units of physiology, it's always important to think about the units, remember the units, write down the units, and use the units and definitions. Units of reabsorption rate are milligrams per minute. What it really means is how many milligrams of a certain solute is reabsorbed from the tubules in a certain time period in a minute. And that is reabsorption rate. Secretion. Secretion is a process when a substance is taken from the peritubular capillaries and moved into the lumen of the renal tubules. This also happens at a rate. Everything happens at a rate. So if the exam asks you for the secretion rate, they're asking you how fast is a substance secreted. So therefore, once again, the units for secretion rate will be in milligrams per minute. That's what secretion rate means. How many milligrams, what amount of a substance is being secreted in a minute. Therefore, your units here are milligrams per minute. That's secretion rate. excretion. Now, this is a very important concept to understand. What does excretion mean? Excretion means that a substance is in the urine. If a substance is in the urine, that substance is excreted. How does a substance make it in the urine? Well, I want to take a minute here to make sure you understand the difference between excretion and secretion with an S. If a substance is excreted, that means it has some concentration in the urine. That means it makes it in the urine. How does a substance make it in the urine? How does a substance get excreted? Well, this substance could be filtered and not completely reabsorbed. If a substance is filtered and not completely reabsorbed, it will be excreted. Or the substance could be filtered and then secreted. Then it would be excreted in a larger amount. So, substances that are excreted in larger amounts, those are substances that are filtered and secreted. Now, a substance can be excreted without being secreted. So be very careful here. There are certain substances that can be excreted without being secreted. I want you to think about one, because there's one common one that you will be questioned on step 1, and we'll talk about it later. By the time we get to it, you should know what I'm talking about. Excretion rate. What is excretion rate? Excretion rate is the amount of a substance that is excreted in the urine in a minute. It's a rate. How fast is this happening? How many milligrams of substance X is being excreted in the urine in a minute? Milligrams per minute. That's the definition of excretion rate. So this slide very nicely summarizes all of the renal processes. Blood enters the kidneys via the renal artery, eventually breaks down to the afferent arterioles. After the afferent arterioles, blood goes into the glomerular capillaries, which is where the first process happens. That's the process of filtration. Filtration is a process by which an ultrafiltrate is formed from the plasma in the glomerular capillaries. This ultrafiltrate is formed in Bowman's capsule. Then the ultrafiltrate moves down the tubule. First step is to move down the proximal tubule. In the proximal tubule, you have two processes. You have reabsorption, which is number 2, and then you have secretion, which is number 3. Secretion is very important to understand. That's the process by which a solute is taken from the peritubular capillaries and moved back into the tubules and goes back into the ultrafiltrate within the tubules. That's the process of secretion. Excretion means that a substance is excreted in the urine or placed in the urine. So when you form urine, you form an excretion rate of a certain substance. The equation at the bottom of the slide is very important in understanding renal physiology. This is the equation for mass balances. This equation says that the excretion rate is equal to the filtration rate or filtered load. Another word for filtration rate is filtered load, minus the reabsorption rate plus the secretion rate. So, is the substance excreted or not? Well, that depends on the other 3 processes. If a substance is filtered and completely reabsorbed, the excretion rate is 0. It is not secreted. Now, I want to make a very important point here to know the difference between excretion and secretion. Remember, secretion is when a solute is taken from the peritubular capillaries and moved into the tubules. Excretion means that the solute is in the urine. A substance may be excreted without being secreted. For example, a substance may be filtered and not completely reabsorbed. If a substance is filtered and not reabsorbed, then it is excreted. However, the excretion rate must be lower than the filtration rate because some of that substance is reabsorbed. If you have a substance that is filtered and secreted, that substance will have a very high excretion rate because the excretion rate will be equal to the filtered load plus the secretion rate because there are 2 different processes that place that substance in the tubules and ultimately in the urine. The exam is to ask you to calculate the excretion rate of substance X. You would have to calculate the filtered load, and then you'd have to know, well, is the substance reabsorbed? If it is, you would have to subtract the reabsorption rate of that substance. If the substance is secreted, you would have to calculate the filtered load plus the secretion rate, and you would add the filtered load to the secretion rate, and that is how you would get the excretion rate. Later on, we'll give you some examples of how to do this. It's very important to understand this slide and this concept in renal physiology. So this slide just looks at blood flow through the kidneys. Blood enters through the renal arteries, then becomes the ocular arteries, then goes through the afferent arterioles, then the glomerular capillaries, efferent arterioles, then peritubular capillaries, and that's where you have reabsorption and secretion, vasorector, arcuate vein, and then renal vein. So this is blood flow through the kidneys. Regulation of blood flow through the kidneys. The kidneys autoregulate. Many organs autoregulate. You saw in earlier sections in physiology, the heart autoregulates. Coronary arteries autoregulate, and that's controlled by NO and adenosine. We said the brain autoregulates. Cerebral arteries autoregulate. That's controlled by arterial carbon dioxide. Exercising skeletal muscle autoregulates, and that's controlled by adenosine, lactate, potassium, acid. Those are all organs that autoregulate. Well, the kidneys, they also autoregulate. They're very effective in autoregulation. Now, when you talk about autoregulation in the kidneys, it's all through the afferent arterioles. It is the afferent arterioles that autoregulate. There are two proposed mechanisms. One is the myogenic response. The other one is what we call tubuloglomerular feedback. Myogenic response means that when you stretch the smooth muscle cells of the afferent arterioles, it causes them to contract. So that's quite simply a stretch response. So when you stretch the smooth muscle cells, that causes them to contract, and that causes vasoconstriction. That's the myogenic response. The second response, and this response has more support, is known as tubuloglomerular feedback. And here's how this works. When there's an increase in MAP, mean arterial pressure, this leads to an increase in your renal blood flow and an increase in your GFR. When there's an increase in your GFR, there's an increase in filtration of solutes, including sodium as well as chloride. That means there's an increase in delivery of sodium and chloride ions to the macula densa. What's the macula densa? The macula densa is the portion of the nephron where the thick ascending loop of Henle meets the early distal convoluted tubules. It's the very same nephron. Okay, it's just later on in that same nephron. The macula densa is very important. The macula densa contains sensors for sodium and chloride. When the macula densa senses high levels of sodium chloride, it releases adenosine. Now, the macula densa, if you look at the anatomy, is located very, very close to the afferent arterioles. This adenosine leads to vasoconstriction of the afferent arterioles. When you vasoconstrict the afferent arterioles, that leads to a decrease in the renal blood flow, as well as a decrease in the GFR. I want to make a very important point here. You learned that in the heart, adenosine vasodilates the coronary arterioles, and that is true. In the heart, adenosine vasodilates the coronary arterioles. That's true. However, in the kidneys, adenosine vasoconstricts the afferent arterioles. Different substrates can do different things in different organs. So make sure you understand the difference and do not confuse this. Adenosine vasodilates coronary arterioles, but adenosine vasoconstricts the afferent arterioles here in the kidneys. It's very important to understand this distinction and not get the two confused. Now, if there is a decrease in delivery of sodium and chloride to the macula densa, this will lead to vasodilation of the arterioles, and this will lead to an increase in the renal blood flow, and this will lead to an increase in the GFR. So the opposite is true too. Now, here's how I want you to think about this, because sometimes students get confused with this whole process. Here's how I want you to think about this. Why do you have to vasoconstrict the arterioles when the MAP increases? Well, let's say you have a patient who has hypertension. And most patients with hypertension, 90%, have what we call essential hypertension, which really means we don't know why they have it. Genetic factors, they have arterioles that are just hypertrophic, and they just have hypertension. And they do not take their medications. So they walk around with elevated MAPs every day. So that leads to increased pressures going into the kidneys. Now, if you did not have this effect of vasoconstricting the afferent arterioles, these elevated MAPs would lead to destruction of the glomeruli. So the reason why you need this effect to happen is to protect the glomeruli. So I want you to think of the afferent arterioles as protecting the glomeruli from these high MAPs, from these high pressures coming in and physically destroying these tiny little delicate arterioles, because that can happen. And when this does happen, this is what we call a hypertensive crisis or malignant hypertension, right? And then patients that come in with malignant hypertension with end organ damage, they could come in with acute renal failure. They get hyperplastic arteriolosclerosis. We'll get more of that in the pathology section. But when patients come in with blood pressure that's out of control, they get end organ damage. So this vasoconstriction here protects the glomeruli from this high pressure leading to damage of these delicate glomeruli. So this is why this needs to happen. You need to protect the glomeruli, and that's what's happening here. So that's what I want you to think about this. This is why this needs to happen. So this slide gives you a graphical representation of the concept of autoregulation. Autoregulation means that the kidneys are able to keep the renal blood flow and the GFR constant at wide variations of the mean arterial pressure. So let's take a look. As the mean arterial pressure increases and increases and increases, both the renal blood flow and the GFR remain constant. That's what autoregulation means. This occurs because of the afferent arterioles. Now, if you did not have autoregulation, imagine what would happen. As the MAP increases, what you would see is an increase in the renal blood flow. Like so. The renal blood flow would increase up and up and up. You would also have an increase in the GFR, and that would lead to glomerular damage and damage of the arterioles. But the vasoconstriction of the afferent arterioles will protect the glomeruli. So here's a question they can ask you. They can give you this graph and point right over here. And they could say, here's a patient with the MAP all the way over here. And they could say, what are the afferent arterioles doing at this point? And the answer is, the afferent arterioles are vasoconstricting to keep the renal blood flow and GFR low at this point. Then they could say, what are the efferent arterioles doing at this point? Well, at this point, they would be vasodilating. The efferent arterioles would be vasodilating, and that will be due to decrease in renin secretion. We didn't get to this section yet, but you will see later on that whenever there's an increased blood flow at the afferent arterioles, renin secretion is suppressed. And we'll talk about that later. Now, likewise, it can give you a similar question and say, well, here's a patient over here on the scale. So here's a patient with a MAP down here. What would the afferent arterioles be doing at this point? Well, at this point, the afferent arterioles would be vasodilating, and the efferent arterioles would be vasoconstricting. And this is how the kidneys autoregulate. Again, this means that the kidneys are able to keep the renal blood flow as well as GFR constant through a wide variation in mean arterial pressures. We spoke about other organs that can autoregulate. This is how the kidneys autoregulate. Notice what happens when your MAP is very high. Your renal blood flow increases. This is when you get damage. This is your patient who has a hypertensive crisis or malignant hypertension. This is a patient who has acute renal failure. They get hyperplastic arteriolosclerosis. They get end organ damage. How about down here? This is a patient with septic shock or hemorrhagic shock who now gets decrease in renal blood flow. And this patient can get acute tubular necrosis. So when you fall out of this range, you get damage. Okay, and that is autoregulation. Let's talk about flow. You spoke about flow in the cardiology section. Same concepts apply in the kidney. Blood flows from high pressure to low pressure. Blood flow is a high yield concept in all of physiology. There are two factors that affect flow. Blood flows down a pressure gradient. Blood always flows from high pressure to low pressure. How can you affect blood flow? You can change the pressure gradient. You can decrease the pressure gradient. You can decrease the upstream pressure, or you can increase the downstream pressure. Either one would decrease the pressure gradient. You can also increase resistance. If you increase resistance at any point in that series circuit, you will decrease flow. Pucell's equation is central to understanding physiology. Remember when you took physics and you said, why do I have to know this? This is boring. This is horrible. Why am I being tortured by this material? Well, this is why. If you don't understand physics, you don't understand physiology. You need physiology to become a physician. Pucell's equation is central to understanding all of physiology. Pucell's equation says blood flow is equal to pressure gradient over resistance. P1 is upstream pressure, P2 is downstream pressure, R is the resistance between the vessels. So this is the equation for flow. Looking at this from a diagram, P1 is high pressure, P2 is low pressure. Blood will flow from P1 to P2. Resistance between P1 and P2. If you increase resistance, you decrease flow. It's very important. Resistance is inversely proportional to flow. So anytime you increase resistance in a series circuit, you decrease flow. We are now going to apply this concept to the kidneys. The kidneys are unique because the kidneys, you have two resistors. The kidneys, you have two resistors in a series circuit. You have the afferent arterioles, and then you have the efferent arterioles. If you increase resistance at either point, if you vasoconstrict either the afferent arterioles or the efferent arterioles, you are increasing resistance in a series circuit. Therefore, you will decrease the renal plasma flow. So, when you vasoconstrict either the afferent or the efferent arterioles, you will decrease the renal plasma flow across that series circuit. That's very important to understand. You decrease the renal plasma flow. That's one thing you have to look at. The other thing that's important to look at is the pressure. Whenever you vasoconstrict an arteriole, look at the pressure upstream or before that point of resistance. Whenever you vasoconstrict, pressure builds up or increases upstream or before that resistor. Likewise, pressure decreases downstream or after that resistor. Common analogy I like to give is a hose. You take a hose and you put a kink or bend in that hose. Well, that kink or bend is a point of resistance. Upstream or before that kink, you're going to see the hose expanding. That expansion is the pressure building up before that resistance. That's why you see the holes expanding. After that resistance, pressure will decrease. So that's a very important analogy to think about. Likewise, if you take an arteriole and vasodilate, you decrease resistance of the arteriole, flow across the circuit increases, the pressure upstream from that point decreases and rises downstream. So let's take this concept and apply it to the kidneys. R1 in this slide is the afferent arterioles, R2 is the efferent arterioles, and the pressure in between these two resistors is the glomerular capillary hydrostatic pressures. Now, if you take the afferent arterioles and you vasodilate the afferent arterioles, you, one, increase the renal plasma flow because you're decreasing resistance. That's one. You, two, you increase pressures after or downstream from that resistor. Therefore, you increase the glomerular capillary hydrostatic pressures. And if you increase the glomerular capillary hydrostatic pressures, you increase filtration. Therefore, you increase the GFR. And this is how the kidneys can increase GFR. One way they can increase GFR is by vasodilating the afferent arterioles, because that will increase the glomerular capillary hydrostatic pressures. What you also can do is you can vasoconstrict the efferent arterioles. That is increasing resistance at R2. If you increase resistance at R2, you will increase the upstream pressures, which is the glomerular capillary hydrostatic pressures. That will increase filtration. That will increase GFR. So if you vasoconstrict the efferent arterioles, that will increase glomerular capillary hydrostatic pressures. That will increase GFR. Now, if you vasoconstrict the efferent arterioles, you are decreasing renal plasma flow because you are increasing resistance in a series circuit. Now, if you take the efferent arterioles and vasodilate them, you are decreasing the glomerular capillary hydrostatic pressures. Now, another thing I want to talk about on the slide is reabsorption. If hydrostatic pressure is the force that drives filtration, what is the force, do you think, that drives reabsorption? The force that drives reabsorption is oncotic pressure. Therefore, if you increase the oncotic pressure, you increase reabsorption. So this table nicely summarizes what we went over. Very important to understand this table. Vasoconstrict the efferent arterioles. Vasoconstrict the afferent arterioles. No matter what, whenever you're vasoconstricting, you are increasing resistance in a series circuit, and you are decreasing. You are decreasing the renal plasma flow. Now, when you vasoconstrict the efferent arterioles, you are increasing the glomerular capillary hydrostatic pressures, and you're increasing GFR. When you're vasoconstricting the afferent arterioles, you are decreasing the glomerular capillary hydrostatic pressures, and you are decreasing GFR. Vasodilate. When you vasodilate the efferent arterioles, you are increasing flow because you're decreasing resistance, but you are decreasing the glomerular capillary hydrostatic pressures, and you are decreasing GFR. Dilate the afferent arteriole. Well, again, you're increasing flow, but you're also increasing glomerular capillary hydrostatic pressure. So it's very important to understand this table. Okay, so here's a clinical correlation. A patient with essential hypertension will have an increase in renal artery pressures due to increased flow. That will vasoconstrict the afferent arterioles, and that will vasodilate the efferent arterioles. The elevation in juxtaglomerular pressures will lead to decrease in renin secretion, leading to low angiotensin II secretion, and that will vasodilate the efferent arterioles. Here's a high-yield clinical correlation that step 1 loves to go after. They love to go after renal artery stenosis. Here's what happens. Renal artery stenosis. There is low renal artery pressures, leading to low flow states at the afferent arterioles. This will lead to vasodilation of the afferent arterioles. trying to increase renal blood flow and increase renal perfusion and increase GFR, because GFR is low here. You also will have increase in renin secretion. Whenever there's low at the afferent arterioles, that's a very important stimuli of renin. So the renal artery stenosis leading to low renal blood flow at the afferent arterioles is a very important stimulator of renin secretion. So renin levels will go up, leading to increase in angiotensin II secretion. Angiotensin II will vasoconstrict the efferent arterioles. So you have vasoconstriction of the efferent arterioles. This is an important point, and they love to bring this up. This high level of angiotensin II will also vasoconstrict your arterioles out in the periphery, leading to an increase in your total peripheral resistance. Now, angiotensin II is a very potent vasoconstrictor. This is important to understand for step 1. Angiotensin II is a very potent vasoconstrictor throughout the periphery. Angiotensin II increases the total peripheral resistance, it increases the afterload on the heart, it increases the MAP, and it leads to hypertension. This is a very important cause of secondary hypertension, and we like to go after this on the exam.